we'll start with introductions again. My name is Kwame Adjepong. Some people call me Dr. A, as some people here know. I'm one of the neurologists and a palliative care doctor over at the University of California, San Francisco, UCSF.
And my name is Sarah. I have the great good fortune of being the chaplain in our outpatient palliative care clinic at UCSF. Thank you for having us.
One of our hopes for today is to be able to talk a little bit about Parkinson's disease, of course, and how it changes over time, what we see with it. Sarah and I work together in this palliative care team and figured that today would be a nice chance to be able to talk about how palliative care can be something that can help people that are navigating Parkinson's disease, certainly the people that have the illness itself and the people that are caring for them too. Before we jump in, I'm just curious, show of hands, how many people here have heard of palliative care in the past? A lot of hands coming up.
Wow. Okay.
How many people have seen palliative care in Parkinson's disease in the past? Fewer hands coming up. One of our hopes for today is maybe after this talk and the couple sessions later today, be able to share one piece of information, a takeaway, to be able to share with each other, friends, family, other people about the way that we think about palliative care in Parkinson's disease. Sound okay? Yeah, okay. So, as we're moving forward in today's talk, I want everyone to take the time to take a look at these reflections and I want to answer any one of them to yourself, maybe to the person next to you. With where things are today, what are you hopeful for? Or, with where things are today, what worries you the most about the time ahead? Maybe a similar idea. What are the most important things that come to your mind over the next 1 month to do? How about over the next 6 months? The reason that we spend time asking these questions is because with palliative care, you'll hear us describe, our goal is to be able to make sure that we have these questions front of mind with everything that comes up. Any decisions that need to be made, thinking about what the care ahead looks like. We want to make sure that we're able to have these questions front of mind because at the end of the day, we want to be able to go about the things that are most important to us. Try to enjoy the things that we're most hopeful for and be able to take on the things that are worrisome because there are going to be worries that come up, of course. So like we mentioned, our hope today, of course, we'll be talking about Parkinson's disease and palliative care. We also hope that you get the chance to be able to meet each other and learn from each other today. I know there are a lot of people here that have had the good fortune of being able to meet in the past, and I certainly learn a lot being able to talk with friends and community that are around. And so I said this in one of the prior conversations I was having today, there's a lot of wisdom in this room. And being able to learn from each other is a really valuable way to be able to maintain that sense of connectedness as all of us are talking with each other, learning from each other, navigating this serious illness and the things that come with it. So I think those that know me in the past, when I share this slide, I tend to come over and I'll stand on one side of the stage or the podium and share that I wear 2 different hats. I'm trained as a neurologist and I see a lot of neurologic illnesses, Parkinson's included. I'm also a palliative care doctor and think about the ways that we can provide care for folks with any sort of serious illness, especially the folks with the neurologic illnesses. And so with this slide, I like to share that when I'm wearing my neurology hat and I'm in clinic, I'm really focused on the symptoms that somebody is having. I'm thinking about the time that they've come in, the time they've had those symptoms, the testing that I can do, all trying to get to what that illness is. And of course, thinking about treatments for it. It's really helpful to have a specialty that really hones in on that. And I admit, when I'm in that role as a neurologist, I'm really focused on trying to figure out what that illness is and the medicines to be able to use. Need help with the next slide. I've been really fortunate to see that there's this other kind of approach to care too that focuses on what the experience is like. And so then I move over here and say, when I'm wearing my palliative care hat, I'm thinking about the illness, of course, but I'm thinking about the other things that contribute to somebody's experience with that illness too. The physical things and the medicines are a really important piece, but it's exactly that. It's one piece. I also want to get to hear about how you enjoy spending your day, how the illness gets in the way of you spending your day, what the hopes and worries are, like we were talking about before. And so this idea of being able to put the experience in the middle and moving that illness piece to the side is a really important part of how we approach things in palliative care. And we like to apply that in this instance too, because I don't think I need to tell the people in this room, this illness shows up in a lot of different places in life, and it gets in the way a lot of different ways. And so being able to think about ways that we can try to improve the experience is just as valuable as being able to spend time doing all the diagnostic testing and the medicines and everything that I do when I'm wearing that neurology hat.
I'm going to go forward.
Mm-hmm. And so to this idea, I like to show this picture of a person that has an illness like Parkinson's disease. Of course, it's affecting the individual, and it affects the people that are around them. Sarah and I will often refer to maybe someone's inner circle. Maybe it's a longtime partner that they've been with for decades, and now they're navigating this together. Maybe they have kids or other family members, the friendly neighbors or the community that's around. Everyone is kind of coming together to support this person navigating this illness. If you think about the idea of what a team is like, think about the other team members too. Maybe it's someone's longtime primary care doctor. Maybe they've had the good fortune of being able to connect with a neurologist where they receive that diagnosis. Maybe they're seeing other specialists for any other medical problems that are going on. And maybe they've had the great fortune of being able to work with somebody like Coach, or maybe another rehab specialist, a physical therapist, an occupational therapist, a speech therapist. All these people are part of the team too that's supporting the person navigating the illness and their care partners or their chosen family. We often introduce ourselves as an extra layer of support on top of the team that's already there. And one of the ways that we approach it is with this team-based approach, a really kind of classic palliative care approach is having these different disciplines that are coming together to think about ways to provide support for the person with the illness, but for the people that are around them too. And so we often share that our goal is to be able to think out loud together about what the experience has been like, and to think about ways that we can provide support in navigating all of those things.
And I would add support right to everywhere. We kind of conceptualize of this as an ecosystem, and one of the people in the ecosystem, of course, is the person with the illness. But we also recognize that how well they're doing cannot be separated from the people around them, right? And that every person around them can also have different needs, or the illness can have a different impact on them, their relationship with the person. And so what we've also found is that in order to support patients well, you cannot do that without supporting their loved ones and family members, broadly defined. And from different vantage points, right? Different angles.
I think some people in this room have seen this slide before. I know for some of the clinicians in this room, I share this slide a lot about what palliative care looks like in neurology and in neurologic illnesses in particular. You heard Sarah and I talking about this idea of these different areas that might be impacting somebody's experience. And in palliative care, we think about these different buckets or domains that somebody might be experiencing distress. I shared before that when I'm in my neurology role wearing that hat, I've gotten a lot of training in thinking about the different physical symptoms that might be coming up, something like Parkinson's, of course, super important. We also get training thinking about the emotional things that might be coming up. Maybe in addition to the increased stiffness over time, maybe a tremor, maybe there's increased anxiety, maybe there's depression that's coming up. These symptoms that we see and know are part of this illness are really important for the medical team to be able to identify. We also know that the physical and the emotional maybe are just two of those buckets. And there are a lot of other examples of things that come up that might be impacting somebody's well-being too. And so I feel really lucky to be able to think about it when I'm in that palliative role too, and to be able to think about what someone's experience is like from the social standpoint. Maybe they're part of a vibrant community, going out all the time, enjoying hiking and dinners, and maybe because of the illness, not able to go out quite as much anymore. Maybe not able to drive in the way that they used to. Maybe it's safer actually to avoid driving altogether. And that can be a really distressing change, especially all of us have been enjoying that benefit of driving for so long. Maybe there's the logistical piece, the practical part of it of, wait a second, if things are changing now, what is it going to look like 6 months from now, 2 years from now, 10 years from now? Maybe it's the person with the illness that's asking that question. Maybe it's that care partner or that chosen family we were talking about before, all raising questions saying, of course we love this person, and we're not sure what it's going to look like down the line. Like, how do we think about that? We talk about this idea about one's sense of self and how that tends to change over time too, especially with the neurologic illnesses, and this one in particular. I saw somebody in clinic earlier this week who talked about their love of hiking and how as his illness has changed over time, they haven't been able to get outside and connect with nature in quite the same way. And that's really impacted them because they've spent so much time in the woods, in the forest, and if they're not able to do that anymore, they kind of wonder about who they are as a person. And that change over time is something that we refer to as spiritual distress.
Or loss of identity, right? I think for so much of our lives, we know ourselves through our actions, through the functions that we serve in our families and our communities. So I am the person who, or I am the person that. And so there can be a profound sense of fracture of the self, of self-worth, right? When your body is changing in ways that are unruly or that suddenly take away pieces of you that felt essential to your being and to being able to translate that in the world. That's a very deep pain, right? And it's a symptom of the illness. We recognize that. And of course, the interior experience of illness and the way that we navigate it existentially or spiritually, if that's a piece of our practice, needs to be tended to with just as great care. Because just as much, I would argue, of the suffering comes from those kind of losses of being, losses of self, of being able to contribute in the way we have, move in the way we have, caregiving and care partnering. As grateful as we are, it can also change the dynamics in our most intimate partnerships. So there's a lot that has to do with the self and identity, and what does it mean to be me now, that these pieces that I thought were me aren't there. A lot comes with the diagnosis.
I shared before, I wear those two different hats. And when I'm in that neurology role, I take the time to be really thoughtful and think about all the different things that are affecting the physical and the emotional. I'm thinking about these other buckets too, and I admit sometimes it's hard for me to be able to try to squeeze in all of these important buckets when I'm in that neurology role alone. As a doctor, I have all this training and think about the physical things and the emotional things, but how lucky am I to be able to work with someone like Sarah, a spiritual care provider that's able to really take the time to ask these questions in these other important buckets too. That sense of self, and to be able to share that out loud and talk about it. We notice that sometimes people will tell us when we're in clinic, I didn't know that I can talk to my doctor about this, or I didn't know that this can happen in a medical visit. Yeah, this has really been affecting me, and it's been affecting all of us.
And that's when we know we're doing our jobs well, right? Because if we're saying that we're doing holistic care and you're checking pieces of yourself at the door, we're failing, right? And so the idea that your experience, your suffering, all of it together, again, an ecosystem. And where can we make changes, right? And take it seriously, all the places that it hurts, whether it's in your body, in your heart, in your relationship to your family.
I spend time meeting other neurologists that are also going through training, and a lot of them who move on to care for people with Parkinson's disease and other related conditions. And we share this slide a lot and talk about the importance of being able to ask the person with the illness about questions in each of these different buckets. We also stress how important it is to then turn to the care partner and ask some of these questions too. Mm-hmm. This idea about the spiritual distress or the sense of self, talk about something that we hear from care partners when they sometimes say, no one's ever asked me before about how I'm doing or if I chose to be in this role as a care partner. Or, of course, I love my loved one and I'm still working. I'm still doing all these other things. We had all of these other plans and now those are on hold because I have this new role that's thrust on me as a care partner and I don't know what to do. Like Sarah mentioned before, being able to hear about that from the person with the illness and the people that care for them is really important because all of that impacts the person with the illness too. I had one mentor tell me when I was going through training that maybe one of the most impactful ways that we can help manage an illness like Parkinson's is to be able to support the people that support the person. And so we take the time to be able to ask them how they're doing, how they're navigating, what their worries are, what they're most hopeful for. All of these same questions that come up in palliative care for the person with the illness apply to the care partner too. Next slide. And so both of these slides come from a large scientific paper that looked at what palliative care in neurologic illnesses can be like. This triangle points to different ways that clinicians will think about being able to identify these needs that people have for palliative care in their different neurologic illnesses. At the bottom, maybe it's asking key questions. So for example, I can ask questions about someone's tremor, maybe they're walking. Maybe when we're in clinic together, Sarah or I will ask where somebody finds their connection. Maybe it's to another person, maybe it's to a community, maybe it's to a faith practice. And then we ask, do you still have access to that connection? It's one way that we try to ask a question that's in that spiritual domain that we were talking about before. Maybe we turn to the care partner and we ask, logistically, how are things going when it comes to the amount of care at home? Is it enough? Who's part of the team that's providing care? Is it just you? Is it you and family? Who are the other people that are part of that inner circle? Does that feel like enough? Some of these screening questions are really valuable to get a sense of where things are now, because we know that with an illness like this one, when things change over time, maybe the stuff that's helpful in this moment might require more support down the line, and it's worthwhile to be able to screen for these different things. After being able to ask those questions, like that bottom, the triangle, we get to the next level of identifying those different buckets that maybe are the most distressed. Being able to figure out what things can be addressed in that doctor's office, maybe what things need additional supports like we shared before with physical therapy and occupational therapy, maybe with a social worker to be able to handle some of the logistical things. Take the time to figure out what items can be addressed and who's best equipped to address them. I come to you wanting to think about ways that I can help in most ways that I can, and my role as a doctor is a small piece of it. Also need that team approach to be able to identify these things too. The top of the pyramid refers to the folks that get referred over to what we call a specialty palliative care clinic. And so maybe it's a clinic like the one that Sarah and I work in, where they have a doctor, a nurse, a social worker, a spiritual care provider that has that additional training in palliative care to really think about all of these different domains. We spend a lot of time thinking about ways to be able to provide palliative care even before someone gets referred over to specialty palliative care. And I'll share, a big piece of it is being able to identify what things are important. In a doctor's office, again, they might ask about the physical things, the emotional things. Of course, you all know about the things that are most important to you, and being able to have a space to be able to share that and ask the clinic, hey, how can we address this change that I'm experiencing? Kind of brings that conversation about palliative care to the forefront.
Keep going.
I like showing this slide because this idea about palliative care and Parkinson's disease, I like the show of hands before showing that people had heard about palliative care. I'll share that in the past, some people felt that palliative care was very specific for certain illnesses. For example, cancer. And it's been more of a recent wave of support for palliative care in other illnesses outside of cancer. And these are just a few of the organizations, of course the Parkinson Foundation included, recognizing the benefit of palliative care in Parkinson's disease in particular. And in the other neurologic illnesses, maybe in things like dementia, maybe in things like Lewy body, all of these different illnesses that come up that progress over time, palliative care has been found to provide a benefit in being able to address these different domains that we've talked about. And so we spend time today talking about how important this is and recognizing and thanking the foundation that have also recognized this too. And so for those that have reached out wondering about ways to be able to participate, these organizations have recognized the importance of palliative care through the work of the people that are part of them. So being able to recognize and advocate for palliative care services and what that looks like, it helps these organizations think about the things that are most important to the people that are part of them. So we've gotten a few questions over the years now that a talk like this has been given about what to expect with palliative care, how to think about palliative care with neurology. And so we figure that we can put up some of the most frequently asked questions and start to touch on them in hopes of being able to provide some answers and this idea of having a takeaway from this. And so the question that comes up is, what actually happens in a palliative care visit? Like, what do you do when you're there? And I'll share that some of the things that are on this slide, I'm sorry the text is small, speaks to the things that we talked about before. For example, someone comes to our clinic, maybe we'll meet Sarah and I. At the same time, maybe we'll have our social worker there, our nurse there too. They get to meet the entire team that's providing that extra layer of support. And in that visit, we're asking those questions, targeting those different buckets that we shared before on that pie chart. As we hear from you and hear about where things are most distressing, we often say, let's think out loud together about how to prioritize those different buckets and how to go about being able to manage them. We often say that we don't want you to have to think about things alone. We don't want you to have to worry alone. It's a chance to be able to share and put on the table all the things that are of concern. You recognize them. There can be a lot of distress that comes up just from the uncertainty of who to talk to and where to talk about it. And so sometimes one of us will end up saying, this can be a space where it's okay to open that box. You know that box that's in the corner of the room that you don't want to open? You don't know what's in there, you don't really want to look at what's in there? Sometimes being able to have a space where we can say, hey, let's open that box together and ask some of the hard questions that are hard or uncomfortable to talk about. That could be a space, a palliative care visit can be a space to start to open that box and answer some of those questions.
I'll say it's also we follow you, right? And so just in the same way that we try to get to know what makes life meaningful, what makes you you, right? Where is the purpose or where is the hope? The organizing principle is your own values, right? Of course. And so as we're getting to know you and getting information, and again, as Dr. Adjepong said, so often people are like, why on earth are you asking me, bringing me joy or this or that? And the truth is that in palliative care, and particularly in the context of Parkinsonisms, we often have the great benefit of traveling with people for a long time. And the better we get to know you and love you as individuals, truly, right? Then we can figure out what's the organizing principle of this life that gives it joy and meaning, and try to arrange the other things around it to support that. And of course, you're the expert on what gives your life joy and meaning. And so what we try to do also is, from our very different disciplines, to work together, where Dr. Adjepong on maybe physical symptoms, I may be looking at I keep doing that, at the inner life, right, that people have. Our social worker may be also working on the very, serious kind of systemic or healthcare related or resource related issues, of course, that also impact quality of life. And so I feel like you get someone not just checking out the spacesuit, but making sure that what's inside is also feeling okay, and that you're cared for, and according to your own measure, right? According to your own measure. Yeah.
Different pieces of this. You heard Sarah mention being able to talk with a social worker, being able to have someone check in on what's going on the inside. When people get referred to specialty palliative care, depending on the place, they may have each of those different team members all together. But I'll share kind of very practically, it can be hard to be able to get referred to these different places, and one can still receive palliative care without being referred to one of those specialty places. Mm-hmm. Being able to ask your doctor about these other domains might make them say, you know what, as the doctor in this role, I actually don't have a medicine for that feeling on the inside, that spiritual distress, but we can think about the resources that are available to us in our community that might be able to touch on some of that. Maybe being able to get connected to a social worker can be a separate referral that happens. It doesn't have to be in a palliative care space alone, but now have the language to say, hey, having some logistical questions and would like to be able to talk with someone like a social worker about these things. Where's the best place for me to go? And so we talk about this idea about palliative care being provided in different spaces. Yes, it could be in a specialty palliative care clinic, but it can happen in other instances too. Another really common question that we get, I should have asked before if some people have heard about palliative care and about hospice care. And I'll share that sometimes people think the two overlap, or that they're one and the same. And I like to share that this idea about palliative care is that we have a team of people with each of our different backgrounds thinking about the ways that we can support you. Another saying that I got from another mentor is that palliative care can happen at any age of a person in any stage of the illness. Any age and any stage, she likes to say. When we think about hospice care, they use that same approach of being able to think about the different disciplines providing support to somebody in a very specific instance when somebody is approaching the end of their life, thought to have a prognosis of 6 months or less. It's a wonderful service in their spirit of trying to provide support, and in that way, perhaps it's similar to what we do in palliative care. But we take care to separate the two and say, if a doctor says, have you thought about palliative care, it doesn't necessarily mean that they're suggesting hospice or that they're saying that time is getting really short. You might be thinking about that idea of being able to provide additional support, that extra layer of the different team members to be able to help with the current experience at this point in time. It's actually a really common misconception that comes up about this palliative care and hospice. So much so that when we go and we talk to people and they say, wait, if palliative care is a team of people providing additional support, why doesn't everybody get palliative care? Like why would we withhold it from people? And we share that, like I mentioned before, maybe in the past people worried that palliative care was very specifically for a certain type of illness at a certain stage in that illness. And so sometimes, I admit, when I'm in this role and I'm talking to other doctors that I work with, there might be some confusion there too, saying, wait a second, someone's not ready for palliative care because they still have years to live. And I say, sounds like a perfect time for palliative care because we want to help that person continue to live. I shared before the other challenge that comes up about palliative care, I admit, like other medical specialties, has a shortage. And so there aren't enough palliative care clinics and offices that are spread around the country, let alone in California. And so sometimes it could be hard to get a referral to that specialty palliative care place. Goes back to what we were sharing before about being able to identify the pieces of palliative care and ways to still be able to receive it, even without getting that referral to some specialty place, working with a social worker, having that conversation with the doctor too, saying, hey, these are the other domains in our lives that are being affected as well. I mentioned that scientific paper before that was looking at palliative care in neurology. And this is another picture that came up where they took a look at people that had a lot of different neurologic illnesses, Parkinson's included, and looked at the palliative care needs over time. The physical, the emotional, the spiritual, the practical, the logistical, all of these things that they were looking at over time. And they noticed that it seemed like a roller coaster ride. It really fluctuated what those needs were over time. Sarah and I were talking about this earlier, that somebody might have their physical symptoms relatively stable. Things aren't really changing week to week, but maybe for the care partner, a lot is changing. Maybe they've been supporting for years and years, and it really is weighing on them because it's a marathon, not a sprint. And so the palliative care needs are increasing because the logistical things are increasing, even if the physical stuff has stayed the same. Maybe they're able to talk with their doctor, maybe they met with the palliative care team, able to think about ways to provide additional support, and those needs come down again to a certain extent. Fast forward another year or two, maybe there are physical changes. Maybe something else has also changed too, and those palliative care needs increase again. And so this graph shows how over time, that bottom axis is over the course of years to even decades, the palliative care needs come up and down. And when people are experiencing that peak of palliative care needs, that could be a crisis. That could be a time where there's a lot of important questions being raised. It could be for, again, the person with the illness, for the care partners of the person with that illness too. And we hope that with a session like what's happening today, empower you to be able to share when you're experiencing that type of distress in these different domains. Because we often talk about how Parkinson's disease has a lot of different symptoms that are parts of it. And we argue that maybe some of the palliative care needs that increase over time, that could be another symptom to think about with Parkinson's. We know that this happens over time. We know that this illness plays out over several years and decades. The same way that people might experience slowing down when they walk, tremor. We know that there might be the feeling of constipation or anxiety or lightheadedness. We know that a care partner might be able to provide all of the support at home until someone has a hard time getting up and walking on their own. Maybe the care partner doesn't have the physical strength to lift somebody. We know that this is coming over the course of an illness like this, and to be able to have a space to be able to think out loud about what the plan is, if that happens, when that happens, is one way that we think about being able to help bring that peak of palliative care needs back down again as much as we're able to. And so, we spend a lot of time sharing this information, and we love to have the back and forth. I wonder if for today, at least for the next couple of minutes, you can turn to the person next to you and just share one takeaway. If there was one thing that you heard from the two of us that you have a question about, that you learned about, and you wonder being able to apply it to your own day to day, turn to each other and share something that came up.
All right, you can stay seated if you want. If anybody wants to stand up, you can do that too. Just make sure you have a little bit of space in front of you and to the sides so you don't punch anybody. If you accidentally punch somebody, it happens. All right, let's go over the basics. So there's only really 3 punches. Straights, right down the middle, 1s and 2s, we call them. Hooks, coming around, 3s and 4s. And uppercuts, 5s and 6s. All right, so left straight is a 1. Right straight is a 2. Left hook is a 3. Right hook is a 4. Left uppercut is a 5. And right uppercut is a 6. There you go. All right, let's put together a few combos. This is the crash course, the fast course. We're going to go 1, 2, 1, 2. Left straight, right straight, left straight, right straight. We're going to go 1, 2, 3, 4. Left straight, left hook, right hook. We're going to go 1, 2, 5, 6. Left straight, left uppercut, right uppercut. All right, let's have a little more fun with this. We're going to go 1, 1, 2, 2, 3, 4, 3, 4. Left straight, right straight. Left hook, right hook, left hook, right hook. We're going to go 1, 2, 3, 6. Left straight, left hook, right uppercut. We're going to go 2, 1, 2, 3, 4. Right straight, right straight, left hook, right hook. Your other left, Dave. All right, let's get a little more challenging combos now. Let's go 1, 1, 2, 3, 2. Left, right, left hook, right straight. What? Let's go 2, 1, 2, 5, 6, 3, 4. Uh-oh. Right straight, right straight. What did I say? 5, left uppercut, right uppercut, left hook, right hook. We have a rule in class. If all else fails, just hit the bag. Okay? All right. Let's go reverse now. 6, 3, 2, 1, 2. Right uppercut, left hook, right straight, left straight, right straight. All right. Let's go 1, 2, 3, 6, 5, 4. Uh-oh. Left straight, left hook, right uppercut, left uppercut, right hook. All right, let's go rapid fire right down the middle. Here we go. How about a little voice activation here? You want to count down with me from 10? We'll go 10, 9, 8, 7, 6. Speed it up. 5, 4, 3, 2, and 1. All right, that's it. That'll help us digest that food a little bit. Thank you.
Oh, hello, you.
Hi, everybody. We're back. I promised that I would do this again. For those that are sitting in the back, show me a thumbs up if you're able to hear me okay. Okay, way more thumbs. Glad to hear it. I'm not going to move around this time, I promise. Welcome back from lunch. I'm really happy to be able to take the time to introduce our panel, and we'll have each person introduce themselves, their role, their experience with Parkinson's disease so far, and then we'll jump into some questions that came from this group for each of the different people. And so I wonder if we start on the far end with the illustrious Dr. Z.
I'm not sure I've ever been called illustrious before. Thank you for that intro. It's really nice. I'm Rafael Zuzuarregui. I'm from UCSF. I'm a movement disorder specialist. I've been in practice for 8 years now, almost 8 years. And I primarily treat people with Parkinson's disease, but also focus on sleep disorders in Parkinson's.
And I'm on the slides, Patricia Kirby, but everyone knows me as Patty. So my husband has Parkinson's. It's been about 4 years that we've been dealing with this. In my family, my grandmother also had Parkinson's and died from that, and I was a little bit too young. I knew what she had, but I really didn't know a lot about it. And at this point now, one of my brothers also has Parkinson's, and that's okay. But he got it fairly young and has been dealing with it. But so it wasn't completely new to me, but dealing with it day to day and trying not to let it change our lives too much has been
Very difficult.
not always. Something we've had to make adjustments, but overall, I think we try and stay very positive about things and keep doing as much as we can and not let it slow us down.
That's what I would say if I was saying it first.
Say who you are. How about you introduce yourself?
Oh, I'm Rad, Patty's husband, Rad Kirby. Been stricken with this for about 4 or 5 years, I guess. All of a sudden, going along with life, and it makes a big turn on you. You have to get used to dealing with the new set of rules. So, that's it.
Okay. And I'm Kelly Darakjian. I'm a care partner for my husband. And we're active in the Parkinson's community. I'm on the leadership of the Greater Fresno Parkinson Support Group. But on top of that, we're also very involved in Rocksteady and Exercise for Life Foundation. From that standpoint of what we do, my background is that I am a registered nurse, now retired, because again, Parkinson's affects the family. But in addition to that, we also, we go to UCSF is where we get our medical care. So Dr. Z happens to be our physician, but we have also taken advantage of the palliative care through UCSF. So we have personal experience with what that is like and how helpful it is.
Good afternoon. My name is Hrant Darakjian. I have been diagnosed, it's been 12 years ago I've been diagnosed with Parkinson's. So I'm still here today, so I attribute that to exercising. I've been with Johns for 10 years now together in a group setting too, to exercise, and life goes on. Unfortunately, there's, like they were saying, there's changes all the time happening in your life, and sometimes it gets frustrating, but we still keep on going because there's hope at the end for us. I'm also retired from being an accountant. 5 years ago, I had to close my business down because of Parkinson's. So, but I'm glad I did. So my wife and I take care of each other, and she takes care of me. And it's always good to have. Thank you.
My name's still Sarah. I think I still work at UCSF, hopefully, in the outpatient clinic. Yeah, so I'm the chaplain on our team.
Again, thank you everybody for being here. And thank you everyone in the crowd sharing questions ahead of time. There are a few here that we'll go through, and we'll have each person on the panel answer some of these questions. Also learned today that additional questions, of course, will be coming up after this. I think something that Bruce mentioned was that sometimes after a session like this, there are more questions than answers, and that's okay. So you'll have note cards at your tables. Continue to write down questions as they come up. We'll answer some of them. And additional questions that come up, make sure you share them with the staff that's here so we can work to be able to get answers to each of these questions that can be placed on the Greater Fresno Parkinson Support Group or other places to be able to find answers to these really important questions as they come up. To that end, I'll get started. I'll work on the far end again with Dr. Z. One question that came up from a doctor's point of view: what are the best ways to communicate or use the time in the doctor's appointment with you?
Wow, that's a really open-ended question, really important question. I think Dr. Adjepong really summed it up nicely during his talk when he said that he wears multiple hats in his visits, where there's the neurologist and then there's the palliative care doc. And as a movement disorder specialist, I tend to focus on the things that affects you, the way that Parkinson's is affecting you. But I think the best way that we can use the time in the visit is if you come to the visit with your top 2 or 3 specific concerns that we can address in that visit. One of the really challenging things about working in healthcare is that we have a limited time in our appointments to address all these issues. And gosh, Parkinson's affects so many different parts of your body, your brain, your life experience, and it's impossible to cover that in 30 minutes. So I think if we prioritize a set of things that you're really struggling with that we can try to help with, that might optimize and maximize the time that we use in the visit.
Thanks, Dr. Z. Yeah, it can be such a challenge to try to meet each of the different things that come up, and I feel like sometimes I'll even be in a visit in neuro or palliative and say, these are important additional questions that we might need to touch on in the next visit too, and we'll have that at the top of the list.
Yeah. Or sometimes we use MyChart, which is a way to communicate with your doctor in between visits if there are other concerns that we're not able to address in the visit itself.
Patty, I wonder if we continue with this theme of being able to bring items up in a doctor's visit. There might be so many things that are coming to mind, particularly in the role of providing support for somebody. How do you go about even deciding where to begin, what questions to ask in that visit, specifically from the role of a care partner?
Well, I think similar to what Dr. Z said, I try and think ahead of time that what are the things that have been bothering me, what have I seen that we need to discuss with the doctor, and then making sure I talk with Rad and see what, are there issues, are there things that he's been worried about, you know, what's causing this or what's causing that, and try and, usually we find we're on the same page about things, but not trying to overwhelm the doctor visit, because then we end up coming out, neither one of us really knowing, well, what was accomplished, it's too much, you know, but concentrate on what's most important to us at that time. And we do use MyChart to communicate in between times, you know, we'll send a message to the doctor, and we use UCSF is where Rad's provider is also. And we'll send a message to her in between times if we have a question, and she's very good about getting back to us. So.
I feel very lucky when you can know what to do with all that.
Yeah.
I wouldn't know what to do with it.
Rad, one question that came up in our conversation earlier today was about how there can be a lot of doctor's appointments. It's a lot of time spent dealing with this illness, other medical things that are going on. How do you balance your time going to medical appointments and focusing on the other things that you want to enjoy in life?
Boy, that's a good one, because it seems like when you get to a certain age, every time you turn around, there's something else is going wrong. So between Rad's appointments, he has some eye issues, so we've got eye appointments. He's an old man, so we've got urology appointments. We have cardiology appointments. The primary doctors, like every time, and then add mine on top of that, and then plus my mother's in town, and I have my mother's appointments to balance too. So there's some weeks that I feel like all I do is drive someone to a doctor's appointment, but I try, we do the Rock Steady boxing, and so I figure I try to get appointments on Tuesday and Thursday afternoons so it doesn't interfere with our exercise classes, because we both really enjoy that and feel like we're getting a lot of benefit out of that, both of us. So I try and save Tuesday and Thursday afternoons for doctor's appointments as much as I can. We have a daughter in town, we have a grandson in town, so if necessary, we call on them to help. But it's a balancing act. Yeah.
It sure is. Kelly, I'm curious, this is the same idea. We've talked about it certainly. It came up in our luncheon session about the role of being a care partner. It's a job and a half, at least.
Yeah.
The same idea of all of these doctor's appointments for the person living with a serious illness. How can a care partner find or squeeze in time, maybe in those visits, to focus on themselves too?
I think you also need to be self-aware enough of what needs to end up going on. At our appointments, ever since, at least with the Parkinson's, when we started seeing a neurologist, I went to every appointment with him, even though, for primary care, he was kind of going on his own. And I would take you end up hearing when you end up going to a doctor, a lot of times you go in there with the intent of talking about something, and then you walk out of there not having talked about half of it, or having even brought it up. So I would take notes ahead of time when I saw a new symptom for him, or when I saw something of concern that I wanted to bring up, whether it was physical, whether it was depression, whether it was the fatigue, whatever those issues are, and everybody has their own list. And I use the Notes app on my smartphone, because if people say write it on a note, well, what if you don't take the notebook with you? Because I can tell you, I leave it at home. I use the Notes app on my phone, and so every time I saw something new that I wanted to bring up, I'd go ahead and jot it down, just bullet point it, so that by the time we got to the doctor's office, I had kind of that list of something that we could end up going over, realizing, and you can't go over everything that goes on, but then being able to prioritize what is going on, and giving that picture of what has been happening in that meantime. From that standpoint. So.
Thanks, Kelly. I think with all of these things going on at once, it can feel overwhelming. Mm-hmm. And I like how you're describing one way to be able to maintain a level of organization, even with all of these things going on. Yeah. Hrant, a question that came up was about all of this talk today about palliative care and about the benefits it can provide. Yes. Some people share that it does sound pretty nice. They're also curious about maybe what the impact has been for you, for anyone in this crowd that's thinking about participating with palliative care. Are you able to speak to some of the benefits that you've been able to experience with the team?
Yes, I think it's been very positive from doctor and from the chaplain here. I look forward to talking to them when I think it's every 3-4 months. We get on Zoom, which makes it easier and convenient. And you can talk any subject that's in your mind or something that you're concerned with. You can talk to them about. And sometimes forgot.
It's okay. You can end up talking about maybe what some of those future concerns are. We've started seeing freezing. I'm sorry, I'm going to give out his information, but we've started to see freezing and starting to see those differences in his walk and the shuffle and how much he can walk. And it's like, okay, when is that day going to come that we're going to need an assistive device? What are we going to do? And those are sometimes those topics that we end up talking about. We know that it's probably going to come. Many times it's a when, not an if. But how are we going to navigate that? Because that's really hard emotionally to handle. And so that's that conversation of looking at what have we done in the past to cope, and how did we handle those other transitions, when he had to retire, when he got diagnosed, and all the other little transitions. I mean, he loves to cook, but yet he can't cook anymore. Those are all takeaways. And how do we handle whatever your personal takeaways are, and end up doing with that? But at the same time, talking about, okay, how does that affect the spirit? So he does meet with Sarah to go over more of those emotional aspects. When we're with Kwame, it's usually the two of us. With Sarah, he's meeting individually, but I do want to let you know I have the option to meet with her also individually. I just haven't done it at this point in time. That's subject to change. In other words, palliative isn't just the patient. Palliative truly is the family and those people in that immediate circle.
The kids.
So.
You and your kids.
Yeah. Next appointment, hopefully we're going to have our kids on the Zoom. They've been a little hesitant to do that, but I think it's important that, and as Kwame put it, he just wants to meet the people that are important in our lives, so that we can build upon that and make sure that my kids are okay too. So, and again, they're not kids, they're in their 30s, but.
They'll always be your kids.
They are my kids.
Thank you both. I think this idea of being able to have a space to be able to talk about anything that's on your mind, like you said, Hrant. There can be, I'll share for myself, maybe there are times where I might come into a meeting and I might have an item or two on my list that I want to talk about, especially when I'm in that neurology visit, because I'm thinking about the medicines or thinking about side effects, and they're important items to talk about. And how wonderful to be able to focus on the things that are very specifically on your mind that day. Maybe it's something that just came up that morning that we can spend time thinking about out loud together. To that end, you're sharing a little bit about it already, but Sarah, I wonder if you can share more about maybe some of the things that might come up in that session where you and I are together, or meeting one-on-one with a Hrant or a Kelly. The role of a chaplain on the team and how you've seen the benefit.
Sure, absolutely. I think the first thing I'll say is just very clearly in our clinic, and we still use the words chaplain all the time, but the words we use in clinic is spiritual care provider, because we want it to be very clear that you need not be religious or any kind of ilk of religious, right? It is about your interior life, your values, your meaning-making system, where you're finding hope, where you are hurting deeply, right? If there's a fracture in the sense of self or self-worth, trying to navigate, what the illness has taken and what it means, but also where we can pivot, right? We don't want to leave any joy on the table. And sometimes when we lose one ability, we aren't given the chance to pivot or to process through that, right? And so in a meeting with me, oftentimes, it's directed by the person, right? So what is on your heart and on your mind? A lot of my training and background is in mindfulness and counseling, but mostly in accompaniment and discernment, right? So according to what is sacred to you, whether that be your ethics, your family, the redwood trees, how can we bring more of that into your life to support you where it hurts? If you need new tools, right, can I help you get those to be able to build some more resilience? A lot of it, I think sometimes actually maybe the most important thing I offer is a chance to unburden yourself entirely and not have to worry about the ears it's falling on. Because so many of us, and I include myself in this, right, who have neurodegenerative illness in our families, who are care partners or patients, most people we're interacting with, we love them and they love us, and somewhere in there we're trying to spare each other something or some pain. And so oftentimes the invitation is like, come in here, like this is the place. We can go to the darkest places, we can go to the lightest places, but the space will be held. Your dignity will be centered, right, in that space. And I think, again, there's a lot of emphasis about where is there suffering and might we be able to provide relief, but I think that we also really think about where is there joy, and how can we feed that as well. And so the larger kind of conception is, tell me in your life what is life-giving and what is life-diminishing. And that can be physical symptoms, it can be social symptoms, emotional symptoms, certainly theological pain, right? What does this mean for my family, my relationships? Did I do something wrong? What does this mean for me and God? So kind of all of the pieces that, from where I sit, kind of the us and us that travels in these bodies, there's space for that there. And I also think it's important that there's a place in the medical system that's about very explicitly your humanity and not just the body, right? So that you have clinical encounters that aren't just about a certain kind of medical gaze that tracks maybe decline or whatever it is, that there's something life-giving there. Yeah. I'll say I also do, and not as much, I guess, recently, but the other work I do is legacy work with folks. So if they're wanting to leave behind, right, certain recipes, stories, heirlooms, like what are the ethical wills, the sharing of important stories, making time for that. And we spend a lot of time talking about where there's injury to identity or dignity and how that may be addressed and considered a serious pain and a serious symptom.
Thanks, Sarah. You've taught me so many things over the years we've worked together, especially around that idea of being able to hold a space for somebody to be. They get to be themselves whatever that looks like that day. And so even when we're not in clinic together, sometimes I think about how I can incorporate a little bit of Sarah in my approach too, to be able to keep that space for people to be themselves. I just want to say thanks again. These questions are continuing to come in, and we can continue to share these with our panel. Dr. Z, I'll come back to you. A concern that had come up, especially for some care partners who are gaining knowledge about Parkinson's, they're realizing just how broad the symptoms can be. And they're starting to wonder about if they might have symptoms themselves, or they're wondering about concerns to their physical health that's coming up in their role as a care partner. And so they wonder, is it okay for me to bring this up as a care partner if I'm coming to my partner's visit? Can I bring it up with my partner's neurologist, even if I'm not technically their patient?
Well, that's a tricky question, isn't it? You know, I think as movement disorder specialists, we recognize that treating Parkinson's isn't just about the person dealing with it. It's about the caretaker. It's about the family. It really affects the whole sort of system around that person who's dealing with Parkinson's. And in our visits, a lot of times we do talk about, you know, caregiver burden, caregiver burnout. Those are topics you probably have heard about today from Kwame and Sarah. And I think while I can't treat you for those physical symptoms that you might be dealing with or other emotional symptoms, if you bring them up in the visit, we can at least direct you to, you know, different resources that might help you deal with those issues that you are starting to face. And I think about, you know, social work referral. We're lucky at UCSF to have Kwame and Sarah, you know, where we can refer to their clinic and just get a little more holistic care of not just, you know, the person with Parkinson's, but then also, you know, the person who's caring for them. Or we can help direct you, you know, maybe you should go see your primary care or specialist in that sort of way. So those are things that come up, and while I can't treat it, we can help direct you in the right way to address those things.
I think that's really helpful to hear. I'm sure at least in the luncheon group that Sarah and I were in, we were talking about this idea of having questions and not being sure where to bring it or how to place it, and the importance of being able to bring it up and even have a conversation. I like what you mentioned, Dr. Z, about even if it can't be treated there and then in the moment, at least it's another space to be able to think out loud about the best place to be able to answer that question. I wonder, Patty and Rad, this idea comes up sometimes about a family navigating a serious illness and thinking about the friends and the community that's around them. Sometimes people might say, if there's anything you need, you let me know. And it can be tricky to think about how to go about asking for help, especially from friends or family or neighbors or community. Is this something that you two have navigated, and how have you gone about that approach to asking for help?
Yeah. Well, I think in a lot of things we haven't, when Rad was diagnosed, or even before he was diagnosed, and we started seeing things happening, you know, that we knew something was wrong, we sort of started making changes in our life to, you know, we're getting old, we need to think about what's going to happen in the future. We made a significant move. We had lived up in the foothills in Auberry for about 32 years and moved into Fresno to be closer to services. And it's hard, you know, living up in the foothills with the fire danger and weed control and all of that is difficult. So we made that move to help ourselves and be closer to our daughter. You know, she's in town, our grandson is in town. We don't hesitate to ask either one of them if we do need some help with something. They're both there.
They're always there for us.
They're always there for us.
Always.
And I think I think for them it makes them feel good because throughout their lives we've been there for them. And in a way they feel like, okay, here's a way now we can. I mean, I know they're not thinking we're paying them back, but it's like, we were there for them, they're there for us, and so we feel pretty good about that. I think it's for friends, I think it's been a little more difficult for Rad because making the move into town, he did have to leave his friends behind, and it's harder to make friends. But joining the Rocksteady Boxing, the group that we've met there of people we think of as friends, which hopefully I think most of the people that go to there think of it as one big support group that we're all working together and talking about things and supporting each other. So that's a really good social resource. I worked in Fresno for many years, and so I have friends in town, and a couple in particular that I don't hesitate to call when I need something. We get together, and I can unburden myself to them. So
Well said.
I may have gone off a little bit.
No, I think you nailed it. Actually, as you were sharing too, I was thinking back to something that John mentioned earlier, that Coach mentioned earlier, about this idea about connection, and how the group that we were in, we talked about this idea about how the loss of connection over time can be another symptom that might come up with this illness. And maybe in that way, it requires a lot of active thought to think about how to maintain that connection and what that looks like. And so for some people, it might be hard to be able to ask for help from family or friends. Yeah. And if we think about it like another symptom that gets discussed in clinic, then maybe actually that's one way to be able to manage it best that we can. Being able to ask specific things that a friend or family member can help out with could be another way to be able to maintain some of that connection. I have to admit, Hrant and Kelly, that all of the discussion today has really centered around the resources that are available here in this area. And I see a lot of these questions coming up about where do I find resources? What are the palliative care type things that might be here in the Valley? Where do I go online to be able to just learn about the information and figure out what's there? Do you have tips for where people might be able to search locally for some of the resources that are available here?
You know, I've done some website resources, looking for resources. I mean, there's a lot of resources. Obviously, the Parkinson's Foundation has a huge amount of resources. There's other foundations too, and actually there is a resource list that we have that's back on our table, if you haven't picked that up yet, of just places you can do. But in terms of local resources, unfortunately, we are very underserved, as I think all of you know, for movement disorder specialists here in town. And so a lot of us are looking outside of the area, and we are, like I said, we are at UCSF. But it's not limited to there. I mean, there's, you know, there's Stanford, there's UC Davis, there's UCLA, there's USC. There's a lot of places that there are movement disorder specialists. I believe there's also one in Modesto and one in Bakersfield. But we are underserved, and we're also underserved when it comes to the palliative. I did a search and ended up calling hospitals this week to see who might have outpatient palliative care. All hospitals have inpatient palliative care, and unfortunately that's where you get that mix-up of palliative care. Obviously people start thinking about hospice, because unfortunately when you're in the hospital and you're in that kind of a situation, it's palliative care who comes to talk to you, and that's where that mix-up becomes. And it's so pervasive that my son, who is an ICU nurse, when I told him that we were doing palliative care, he says, "Really? You're doing palliative care? I didn't think that things were that far along." And it's like, it's not. This is a support team. It is a support team. So from that standpoint, so when I check the hospitals, basically, there's not a whole lot out there. Kaiser looks like they might have telehealth palliative care available. And other than that, I get kind of a no everywhere I went. Community does have palliative care, but it is limited to cancer and pain management. That's not helpful to us. There are home care type of places that do have palliative care. I don't know if they would come out to you or what those circumstances are, but you can certainly do a website search for that. To see what they have and whether it's the appropriate one or not. It's certainly, I don't think it's going to be a clinic like what we are dealing with and have the blessing of having. So yeah, resources are a little thin. We do have our support group that is there and available. If you go to there's a contact us page, you can actually call quite a few of us on there, and we can try to help direct you if we can. from that standpoint. So we will, do what we can to kind of support you about what is available out there. But there are other things. CSUF is here. Their grad students work both in speech and in physical therapy, depending on the program, work with people. And so you are benefiting from physical therapy or speech therapy basically for free while their grad students are working with you, and I can tell you it is extremely beneficial. My husband's been part of that for several years now for both of those things. It's what keeps us going, because when you're looking at physical therapy or speech therapy, your insurance is only going to cover X amount of visits. This is something we've been able to do almost year round. So there are resources that are out there that it's a matter of kind of reaching out to us. Potentially, to see what we can help and where we can end up directing you. But unfortunately, like I said, there are not enough movement disorder specialists in town. We do have other neurologists, but again, we're pretty limited. And but in going to UCSF, we do telehealth. You don't necessarily have to travel all the time. Maybe it's traveling once a year. We go a little bit more often because we also have deep brain stimulation. So we do a little bit of fine tuning of the programming. But for other people, it's not that common. So you're thinking, okay, wait, I don't want to drive up to San Francisco all the time. I don't want to drive to LA. There are options with telehealth, and it does work with Parkinson's. So.
Thanks, Kelly. I think those that were having individual conversations with me earlier share this idea too, that we wish there were way more resources available, evenly spread out in this state, around this country, and it does require this maybe creativity to think about ways to be able to receive some of the services that we know are beneficial for the person navigating this illness and the people that are around them too. I appreciate your sharing this idea about telehealth, and it was one that's come up now too about if telehealth actually provides that same benefit, is it quite the same? And Hrant, I'm curious from your point of view, whether it's with movement neurology with Dr. Z, palliative care, what's your impression of these telehealth virtual visits? Do they seem to provide a benefit in a similar way that an in-person visit might?
Yes, it's not 100% like being in person, but overall works really well. Works really well to go to the telehealth, because we're doing, he's watching us as we move around, walking and doing our finger motions and doing different things, so we can see where are we at our level. So I think it works out pretty good for us, yeah. Again, saves you time to 3 hours drive to San Francisco and come back, so it's a big benefit for us. Yeah, I enjoy that, yeah. Only thing I see because of my deep brain stimulation, it's hard to program that. Yeah. That's the only thing I see the negative part of it. But I would get that done once a year. We're in it with his office, the doctor's office. He takes care of it and fine-tuning my DVS batteries, yeah.
I was so nervous you were going to say my barking dog has really disrupted your telehealth experience.
That happens.
I was going to say with the telehealth, if that is something that you're doing for neurology, two of you do need to be there so that while he's walking, while he's showing his motions, I'm using my iPad, or you can use a smartphone, and being able to adjust so the physician on the other end can see what's going on. So it does take, you would need two people available to make that the best that it is, but I would say, and Dr. Z, please feel free to chime in, it works. It really does work, and I think he gets a lot of information. Is it as 100% as being in person? No, but I'd say it's 95%. We're really happy with it.
Can I comment on that too? We really started to roll out telehealth obviously during the pandemic, and as physicians we had to get really acclimated to this form of seeing people, and quickly, because we couldn't see people in the clinic for at least 3 months, and then slowly started to phase people back into the clinic. I would agree with Kelly that pretty much most of the movement disorder examination that we would do in person, we can do 85% of that over video, and we get a lot of information. Sometimes we don't do the full examination, just depending on the context of the conversation. Maybe we're focusing more on palliative care needs and that sort of thing. But there's so much that we can do with telehealth. Now, there's a caveat there. We, as physicians, of course, like to see you in person. It's important to do an in-person examination. But if you're traveling from far away, we understand that that can be challenging, especially for people with Parkinson's who have mobility problems. It's uncomfortable to sit in the car for 4 or 5 hours depending on traffic. So I would say that as a rule of thumb, I try to see people in the clinic at least once a year if you don't have DBS. The rest of the time we can just do video visits. With DBS, if we're actively programming, we need to see you more. Frank knows this, and so does Jim and Kathy, that we have to see you a little more often to do the programming. But once we get to sort of a sweet spot and a more stable place, then we can convert over and alternate like we do with Kelly and Hrant.
Rad's last visit to UCSF was done using telehealth because of schedule issues. But while it was okay, I have to say I think both of us prefer the in-person. That wouldn't be unless scheduling, sometimes you do what you have to do. And it was all right, but I think the in-person visit is, for us, it was best.
Thanks, everybody. It's a nice example of trying to think about those priorities. Remember that I had those 3 questions at the beginning of our talk about what are you hopeful for, what are you worried about, what are some priorities. Sometimes a common one is, I don't want to have to travel to San Francisco or have to travel a long ways away to see a doctor, and being able to get creative about ways to provide support outside of that. Nice to be able to talk out loud about.
I'll never forget, I had someone say to me once, I said, how's life been? And he said, well, as a professional patient, and then dun, dun, dun. And I've started to think about that as a real risk factor, right? That is the feeling of that being one's vocation, is attending doctor's appointments. And so if you can shave a few hours off of that unwanted call, and just hop on a computer, there's been benefit for folks for that. And it's not the same as being in a room with people at the same time, right? Like, both are true.
I see a few different questions here about some of the symptoms that come up with Parkinson's disease, and certainly appreciate people asking about those different buckets that we talked about before, especially around this idea of the logistical and the spiritual distress that comes up. I wonder if we can kind of have everyone on this panel share pieces about Parkinson's. Maybe there could be symptoms that come up that might not be expected. It sounds like, at least from some of the conversations that we've had, there's an understanding that there can be slowness of movement. Maybe there can be some tremors. Some people describe this feeling of lightheadedness that happens. I see a question here, and Sarah, if it's okay, I'll start with you. This question about, is spiritual distress something that happens in Parkinson's? And how do you know if you're having that spiritual distress?
That's a great question. And so I'll broaden it to spiritual and existential distress, just so that we're all kind of can be housed under that. So in my experience, and of course it's not true for everyone, but any experience in our bodies that radically changes what we're able to do, how we're able to move through the world, how we can count on ourselves, how we're perceived, what we can count on in the future, those bring up enormous questions for people that we think about as spiritual or existential questions, right? What is the meaning of my life at this point? Or why is this happening? Or what does joy look like now? Or how do I grieve this appropriately? Or what is, if you're coming from a particular theological, ethical, or cultural tradition, we have been, for as long as we've been living, right, we've also been dying or have had illness. And are there wisdoms that are from a non-medical model, right, that can support me in this time? So I would say, does everyone have that distress? No, I think that there are, like with anything, right, you can have folks having 2 entirely different experiences around the same set of symptoms, right? But I would say more often than not, at some point in your journey, whether that is about what is happening within you, what is happening within your relationships, a loss of a sense of purpose or a feeling of, a sense of diminishment even perhaps, for many people is a feature at some point. And if not for them, right, for their children or for their care partners, there are worries. Or can be spiritual pain, right? What does it mean to support someone not just in body, but to live fully and to access joy, even when, what used to make it possible is now more complicated. So a long-winded answer is saying, in my experience, it's pretty hard to have serious disruption of the body or suffering in the body and not have that affect your heart and spirits. I'm sure it's been done, not by me or anyone I've met, though, I guess.
Thanks, Sarah.
Great question.
I'm mindful of time, Dr. Z. I wonder if I can ask one more question of you around this idea of the different symptoms people experience. There's been a mention about this idea of non-motor symptoms. I know I've been using that term today, and people wonder about if there are different symptoms to be on the lookout for. Can you speak to maybe what non-motor symptoms tend to be and maybe what they could look like in people with a new diagnosis of Parkinson's?
Sure. Actually, this came up in our session too. Dr. Zulali brought this up to the group about the idea of non-motor symptoms. And, as physicians, we try to categorize symptoms based on, to make it easier for us to evaluate and treat things that you're dealing with. And so for Parkinson's, we tend to focus on motor symptoms. You guys know all this: tremor, stiffness, slowness of movement, walking. Non-motor actually ends up being probably the more, when you have non-motor symptoms, it impacts your life in a more significant way as the disease progresses on. And you probably see this in the palliative care clinic, you and Sarah. And non-motor symptoms can manifest as a number of different categories. One is cognitive, so impacting your ability to think, multitask, pay attention, short-term memory, things like that. Can also impact your mood. This came up in our group as well. Anxiety, depression, apathy. But also a lot of people experience frustration, maybe with interfacing with the system, a lack of resources, but also changes that can happen as part of the disease itself too. And under those mood symptoms, I would also incorporate things like hallucinations or delusional thinking or paranoia, things that can really disrupt relationships and families when they do occur. So we keep our eyes open for those things. And then there's things that you don't even think about. Your body just does without you telling it to do. That can be impacted by Parkinson's. One of those things is blood pressure. I'm sure if we asked and polled people in the room, how many people deal with dizziness when they stand up and feel lightheaded? There's probably going to be at least, half of the folks raising their hands. I see you in the front raising your hand as well. A couple in the front. You were in the group earlier too. So blood pressure is one of them. Urination is another. The bladder can become overactive and lead to urinary problems where you go more frequently, more urgently, wake up at night to urinate. There are other things that can cause those, but Parkinson's can have an impact in that way. And then another symptom that came up in our group and maybe in the way how it affects medication absorption is constipation, which can become a major issue in people's lives. Having trouble, having a bowel movement throughout the course of a week can be really distressing for many people. I think those are probably the main categories. I tend to focus on sleep as a non-motor symptom. Sleep can be impacted by your motor symptoms, tremor. Some people get dystonia, which is an abnormal muscle cramping or spasm. But it can be disrupted by other, non-motor things like getting up at night to urinate. People may have hallucinations, so it's scary to fall asleep. And I truly believe that sleep is one way that you can modify the disease course. So bringing this up to your physician and talking about your sleep and trying to get that addressed can be helpful. I would say that that's probably sort of the broad overview without going into too much detail. But as you can see, Parkinson's affects so many different parts of your life, and it's important to talk about these things.
Thanks, Dr. Z. I'm taking a look at the time, and we have about 15 minutes left. We're at 1:30. I wonder, to this idea of non-motor symptoms, if there are symptoms that Kelly, Hrant, Patty, things, Rad, you've experienced so far that maybe came as a surprise, maybe wasn't expected to be part of Parkinson's, that you later learned, oh wait, this is part of the illness too, and how you went about managing those symptoms when they came up?
I think one of the first things before Rad was actually diagnosed with Parkinson's that we noticed that Rad was, before he retired, was self-employed and did sheet metal work, stainless steel, built stainless steel hoods, restaurant kitchens. You know, he had a shop at our house and did all those things by hand. You know, he built parts for custom cars and things. He'd do anything. And he got to the point where I asked him to replace a shelf in one of our closets. And then I'm looking at him and wondering, why is this taking so long? And he would go in, he would measure it, come back, try, put it down, look at it, go back, measure it again, and it was like a constant. And finally I said, what the hell are you doing? You know, what's going on here? He said, I can't think what to do. I don't know what to do next. And that, you know, it just sort of triggered. And then shortly after that, tremors started, and we ended up going to the primary and on our way to the neurologist. But as thinking back, you know, and that's still an issue, the cognitive, I think, more than some of the physical. He doesn't have the freezing. He, you know, of course, had some stiffness and things that are controlled with the medication. But being able to plan how to do something and actually follow through, you know, to completion and think, okay, I need to do this next, I need to do this next, has been an issue. And so what we've done is things that because he likes to do woodworking now. He can't do his metal work anymore, but he does woodworking projects. And we try and find plans that have, okay, there's the steps on how to do this. And I'll get him started. And
Come and help me halfway through again.
come and check on him, make sure he's still following the directions.
Haven't cut a finger off.
You haven't cut his finger off, and all that.
So there, good.
No, we keep a close eye on him. But so he's able to still have a hobby and feel like he's doing something and accomplishing things. And our daughter's benefited from it. Other people benefited from his woodworking skills. And it just takes a little extra planning. Yeah. But that's been a big adjustment that we've had to make in our lives.
Hrant, Kelly, I'm curious for the two of you, things you found helpful when it comes to maybe these non-motor symptoms.
He just mentioned smell, but the smell's not a problem for me. But I think it's the level of the fatigue, and I don't, you know, we knew fatigue would go with it, but I don't think we understood or realized just how impactful that is in everything we do. If we're planning on going to the coast, I know that after we get there, he's going to need a nap before we've even done anything. So it really alters plans, and you have to learn to go with the flow with it. But that fatigue and that level of fatigue was, I think, pretty surprising. And you kind of have to learn how to work around it because there's not a whole lot of fixes for that. The other thing recently I would say is also just sleep. I'm going to say sleep patterns. You know, there's REM sleep disorder. We have a little bit of that, and there are some medications that can help modify that a little bit. But just being able to, he wakes up in the middle of the night, and sometimes he's up for an hour to 2 hours. Sometimes he sleeps all the way through the night. It's extremely inconsistent. And wasn't expecting that, which again, that then has an impact on the level of the fatigue. But this, the fatigue was there way before the sleep issues. I wasn't expecting that. And of course, when he's up and down, guess who else wakes up? So I think that was a non-motor that we just didn't expect it to be as much of a situation as it is. And I expect that it's probably going to continue to progress in the future, but that's not something you can necessarily take anything for. For the cognitive stuff, I will say that's something that you make sure you mention to your doctor. There are medications available. We've also dealt with that, and the medication actually has helped. So it's, you need to speak up. Have that list in front of you before you go to the doctor so you don't forget to bring things up.
Thank you, all of you, because this is something that I think in the role that Sarah and I play, we hear about the non-motor symptoms. Exactly like Dr. Z mentioned, can be some of the most distressing symptoms, especially as things change over time. And so being able to have a strategy for them and being flexible with it, because things sure do change. It could be changing month to month, week to week, day to day, but being able to navigate those fluctuations as they come up, I think is a valuable one. There are a couple of questions here that I thought maybe I can help address too about some of these symptoms as it relates to other things that are happening elsewhere in the body. Dr. Z and I might be biased, but there's more going on in the body besides the brain. And there can be a lot of impact for someone that's navigating Parkinson's, especially if they're dealing with things like infections, like a urinary tract infection or a pneumonia. Or if someone goes to the hospital to get their knee replaced and they're thinking about anesthesia or getting medicines in the hospital. Because this illness can impact so many different parts of the body, it is a valuable thing to be able to mention to the other doctors that you're working with. An important consideration when someone's in the hospital to make sure that they're getting their medicines on time. I'll share that working in the hospital, and Dr. Z's have this experience too, sometimes things that are maybe defaulted in the hospital, a regular cycle for medicines, doesn't fit the regular cycle that you've established are really important for the symptoms that you're navigating. And being able to have maybe an example of a schedule or a table to be able to share with the nurse there or the doctors that are in the hospital can be a really helpful way to make sure you're still getting the medicines on time and taking the appropriate precautions when it comes to things like undergoing a surgery with anesthesia or navigating the illness that might be coming up that lands somebody in the hospital separate from the Parkinson's. We're coming up on time in these last few minutes, but I wonder, we shared before that there's a lot of wisdom in this room and a lot of ideas that have been shared. I'd like to go through the panel one more time and maybe ask if there's one takeaway that you'd like to share with the group that you hope they're able to continue doing, especially here in the Valley, but elsewhere too. What's one item that you hope the group would be able to remember from this? It's okay, Dr. Z, I'll start with you.
I'm having a hard time thinking about the answer to that. The one most important takeaway, and these are questions I like to ask people too. I think it's that there are resources out there, and even if they're not local, there are resources and people that are invested in taking care of folks with Parkinson's disease. And I recognize most of the people, here on the that are speaking today are from San Francisco, but I can speak for the fact that UCSF, Stanford, at the very least, are invested in taking care of people with PD. And while it's not optimal to not have somebody, that you can drive across town and see, utilize a telemed, advocate for yourself, get a referral or a second opinion if you're just not sure that you're going down the right treatment path with Parkinson's disease. And so that's probably the major takeaway that I would encourage folks to think about.
And I would say take advantage of the resources that we do have here. The speech clinic at Fresno State, it does a wonderful job. The exercise group has been
Great.
really great. And for us, we try to think about not what can't you do, but what can we do? Instead of thinking, well, he can't do this and he can't do that, so therefore we can't do this. What can we do? And we try and do as much as we can and keep going. We can't travel the same way we used to with the with the trailer and the truck, but we
Found better ways.
yeah, we travel on cruises and airplanes. So we keep going.
I would say one takeaway would be an advocate, not only for yourself, but for the care partners in here to be advocates for the person that they were with. You need to speak up. If you don't speak up, then things don't get addressed. So I think being an advocate is extremely important, and yes, we do have resources. Again, reach out.
One thing I say is, you're not alone with this disease. You have, as you've seen, most of us in this room have this same disease here, so don't think you're by yourself. So There are other people that can help you, and have people that's why it's important to get involved in exercise groups and different kinds of groups, so that way you don't feel like you're by yourself fighting this fight. You're with other people around you.
That was my thought too. Just, I mean, even when there isn't fixing, I think sometimes we underestimate the power of just being together in experiences that are shared, the legibility, right? Not having to explain. So community is a very, very, very powerful medicine. And all the informal communities, right? Whether it's boxing or the foundation, or if it's your dog park or your congregation. The other thing I hope people remember is from the stage here today is the artful pivot, right? So it sounds like you used to work a lot with metal and now you're working with wood. Mm-hmm. And I know that you are a person of just incredible, I still find you to be a person of incredible energy, but that, and you're still doing all of these physically active things. It may not look like it did before, but that ethos that both of you have, that I've known you to have for so long, which is, this is where we find ourselves, like we are going to take all the joy there is to be had and do all the good there is to be done, is something I've found quite exceptional, at least in your family, and have observed in others too.
Sincerely, thank you everybody for taking this time, and thank you everyone for the questions that you shared today. Really appreciate it.